Okay, good afternoon everyone. I'm Dr. Pranita Sahay and I'll be presenting a case of demystifying a case of acute red eye. Acute red eye or conjunctivitis is something that we commonly deal in our day-to-day practice. So this was a 47-year-old male who complained of redness watering in the right eye for last 20 days and reported worsening of symptoms with the ongoing therapy. He was diagnosed as a case of acute conjunctivitis by the primary physician, and view of severe congestion started him on FMLT 3 times a day with lubricants for a week. However, in view of persisting redness and discharge by the patient, he was shifted to Vigadexa 8 times per day in tapering dose by the primary treating physician. He did not have any systemic history or any drug allergies. Systemic examination was well within normal limits. Vision in the affected eye was 612 and the other eye was normal 66. IOP was normal. This is how the right eye looked. There was diffuse conjunctival congestion. Follicles were present. The cornea looked clear. No anterior chamber reaction. Fundus was normal and normal corneal sensations. However, there were some white suspicious areas that we could see on the conjunctiva which appeared as necrotic patches. Similar suspicious lesion was seen at the superior limbus, which on further fluorescence staining showed geographic pattern of conjunctival ulceration or epithelial defect that took up the fluorescence stain. Similarly, the superior limbus also took up a fluorescence stain, and on further rose Bengal staining, we could see fine dendritic lesions appearing at the limbus. And similar lesion was noted adjacent to it at the 12 o'clock position. Hence, we made a diagnosis of right eye viral keratoconjunctivitis with geographic conjunctival and dendritic corneal ulcers, the left eye being normal. The patient was started on topical antibiotic, lubricant, and cycloplegic, along with topical antiviral therapy, acyclovir ointment 3% 5 times a day, and was given some anti-inflammatory for pain relief. This is the day 1 picture. There was decrease in congestion. Also, the conjunctival epithelial defect started to decrease. The corneal defect had almost resolved. And this is the day 3 picture, further showing complete resolution of the conjunctival and corneal lesions. Day 14, now the patient is only on lubricant, and day 28, complete resolution of the conjunctival and corneal lesions. The visual acuity was 6.6, IOP was 14, and the tear film parameters were also within normal limits. Hence, to conclude, this was a case of acute red eye diagnosed as viral conjunctivitis, treated with steroids, who developed conjunctival ulcers and corneal dendrites and resolved with antiviral therapy. So now we need to understand that acute infectious conjunctivitis is mostly viral, of which adenoviral is the most common cause. Treatment is basically with lubricants and symptomatic support. Povidone iodine and steroids have some role, and use of antibiotic is for the doctor's doctor's satisfaction, basically no role in treatment of conjunctivitis. Now, the use of steroids in conjunctivitis should be very cautious. Indications are limited to pseudomembranes and present of subepithelial infiltrates with photophobia and diminution of vision. Adverse effects can lead to prolonged viral shedding, increased IOP, and sometimes exacerbation of the herpetic viral infections in the form of keratitis. So it is important to differentiate acute conjunctivitis adenoviral versus herpetic. While the adenoviral is more common, herpetic infections can also present. They are mostly unilateral infections and worsen with steroids, and also the nummular infiltrates in herpetic infections appear to be larger in size and variable in appearance. That is how we can clinically, to a certain extent, differentiate herpetic from adenoviral conjunctivitis. So every conjunctivitis does not require microbiological testing, but definitely if it's a neonatal conjunctivitis, a recurrent one, recalcitrant to therapy, or severe discharge, or suspicion of gonococcus, then go for microbiological testing. And this is a literature review that is showing various appearances of viral conjunctivitis with geographic ulcers. So causes for which can be both infective as well as drug-induced conjunctival geographic ulcers have also been reported. The drugs reported to be involved are nicorandil and PST injections. Even Crohn's disease, Behçet's disease, and Wegener's have been reported to be associated with conjunctival geographic ulcers, which need to be ruled out. So the learning points are that ocular surface staining can highlight subtle findings. Rose Bengal can be extremely useful in herpetic ocular surface infections. Herpetic infections can cause geographic conjunctival ulcers. Hence, we need to have a cautious use of steroids in conjunctivitis, and timely use of microbiological tests in non-resolving conjunctivitis can be beneficial for patients.